All right, in this lecture, we are going to talk about a framework for diffuse abdominal pain. Abdominal pain is one of my favorite topics to kind of go through because there are literally like so many different differential like things that should be on your differential. It makes it like a really fun mystery to kind of solve. Some of them very benign. Obviously, some of these conditions are life-threatening, right? So it takes a very trained clinician to be able to tell the difference and know what to do next. With regards to abdominal pain, right, like the differential is so long, I decided to break it up. This one will do diffuse abdominal pain, and then I'll one in later this week or sometime I'll do one on more of like the localized abdominal pain where we talk about like right upper quadrant, left upper, lower, right epigastric, things like that. But this one is going to be just focused on like diffuse abdominal pain. All right. So objectives, we're going to discuss hematological cause of diffuse abdominal pain. We're going to discuss a schema for easily thinking through this abdominal pain. We're going to cover all three prongs of the schema I go through, and we're going to look at the history, imaging, labs, pathophys, management of all of these conditions we're going to talk about. So I'm going to try to give you hints and tips and tricks that will point me one way or the other, and then we'll hammer the pathophys and the management for both step 1 and step 2. And then I've got a question at the end where we'll apply our knowledge. Let's see if we can get this done in like 30, 45 minutes. So we have our case to consider. So this was on my Instagram this morning. If you didn't get a chance, we'll go through it now. So we have a 24-year-old woman. She presents with recurrent episodes of diffuse abdominal pain, nausea, and dark-colored urine. She has no fever, diarrhea, or focal tenderness on exam. Her surgical history is unremarkable. Her labs show mild hyponatremia and normal inflammatory markers. Neurological exam reveals a subtle tremor, and she mentions similar past episodes that are often triggered by stress or medications. What is the most appropriate next step in the evaluation? Should we do a 24-hour urine copper excretion test? Should we assess the heme biosynthesis pathway intermediates? Should we perform erythrocyte enzyme activity testing? Or should we order a contrast CT of her abdomen? So take a second, you can pause your screen, think about it. So for this case, we're going to do B. We're going to assess heme biosynthesis pathway intermediates. So this case is screaming at me acute intermittent porphyria. And we're going to talk all about acute intermittent porphyria. So I'm not going to go on too much on this slide, but I gave you kind of why some of the wrong answers are wrong too. So really, when I'm looking at this patient, I see GI, diffuse GI symptoms, neuropsych, so she has the tremor. These patients may also show up with like confusion or, hallucinations, maybe like altered personality as well. So when I see that GI, I see altered personality and this classic episodes of hematuria that are stimulated by stress or new medications, right? So stress could be exercise, it could be fasting, it could be X, Y, or Z. That's really pointing me into the direction of acute intermittent porphyria. So the pathophys we'll talk about in a second. But really, the other options, so why aren't we going to consider Wilson's disease, right? Wilson's disease would be A. That can cause hepatic, neuropsych, and hemolytic features. The episodic nature of this patient's presentation and the dark urine stimulated by stress and medications aren't really consistent with Wilson's. Wilson's is more of like a progressive deterioration, and the pain is usually localized to the right upper quadrant. So that's, remember, that disease is due to copper overload, right? The copper gets stuck in the liver, it overloads, it overwhelms the liver, it gets out, can make its way up to the basal ganglia, can make its way into the eye, and then cause those Kaiser-Fleischer rings. I'll cover Wilson's disease in another lecture at some point. Maybe when I talk about different kind of liver diseases, we'll talk about it then in more detail. C would be something like G6PD deficiency. So remember, that can be stimulated by drugs, right? So that kind of fits the picture. And maybe we might see red urine on those patients. Probably not, though, but potentially, right? Because we're losing hemoglobin in the urine. When I lose hemoglobin in the urine, we classically will have a positive dipstick for blood, but hemoglobin is not, it's not the full red blood cells. So when we do the actual UA, there will be very few red blood cells. That's kind of similar to myoglobin, so things like rhabdomyolysis. It'll be positive for blood on the dipstick because the dipstick can't tell the difference between heme, myoglobin, and actual like full red blood cells. So it gets screened as positive, but when you do the UA for both hemoglobinuria and myoglobinuria, the UA is classically very low in red blood cells in hemoglobinuria and myoglobinuria. This isn't the presentation does not fit at all, right? I would have had to give you something about low hemoglobin levels in these patients that we're not seeing here. I probably would have given you like a peripheral smear of those bite cells and Heinz bodies. Again, when I do my hemolytic lecture, hemolytic anemia lecture, further we'll go on to G6PD. Remember, I gave that microangiopathic hemolytic anemia lecture, which is a small portion of hemolytic anemia, but I'll go into like the whole big thing. So I consider G6PD as an enzyme deficiency that can cause hemolytic anemia, and pyruvate kinase is the other major one. So we'll go into that again. And then abdominal CT, we don't really have any focal findings here. It's like diffuse findings. I don't think this is an acute surgical abdomen kind of situation, so we're not going to do a CT here. Okay. So acute intermittent porphyria, it's one of my favorite diseases to talk about because it's just such a weird constellation of symptoms. And it's really cool to discuss like the pathophys. So it's an autosomal dominant disorder. It's due to a decreased production of profobilinogen deaminase. It's also called, it can be called HMBS. So don't be like tripped up if you see that. This leads to, when we have a destruction of PBG or low levels, it leads to an increase in ALA and PBG, which are precursor molecules. When ALA and PBG accumulate, they can cause neurotoxic effects, right? They can get up into the brain and cause these neuropsych symptoms. So certain triggers are like drugs, like barbiturates, hormones, like estrogen is classic, like a woman who's on oral contraceptives, fasting, and then other forms of stress. They all upregulate hepatic ALA synthetase 1, which makes ALA, right? And we're going to make more ALA, and ALA is going to have a hard time moving through the rest of the pathway because of the low levels of PBG. So then ALA builds up. So again, there's some sort of trigger, barbiturates, estrogen, fasting, stress, exercise, that upregulate hepatic ALA synthetase. We make more ALA, but ALA is not being able to break down further because of a lack of this profobilinogen deaminase. So my diagnostic approach, really this disease classically impacts women. Obviously men can be impacted as well, but it's like classically women between 15 to 50, they have this recurrent unexplained abdominal pain. Okay, they're probably also going to have some sort of neuropsych manifestation too, tremor, and then some of the other like confusion, change in personality type behaviors. I want to get a random urine PBG and ALA on these patients, especially during an attack, right? If I can catch them during an attack, that's going to be the best. We can then do genetic testing and we can look for the gene defect after the patient has been stabilized. To manage these patients, we're going to stop the triggers. We're going to correct their hyponatremia, and we're going to talk about why they're hyponatremic in a second. We can give analgesics and antiemetics. We're going to give IV hemin. Okay, that's like the backbone of treatment, and we'll talk about why in a second. We're going to give glucose if the hemin's unavailable, or sometimes we'll use both. If they have recurrent attacks, we can consider this new guy, givocerin, which is an RNA inhibitor, or we can just give the patient prophylactic hemin. Monitor long terms because this can lead to hypertension, CKD, and hepatocellular carcinoma. So the mechanism behind why hemin and glucose work, hemin is basically heme, right? So it's going to have direct feedback inhibition of ALA synthetase, right? If I give, we're talking about the heme synthesis pathway. So if I give the patient hemin, your body's like, yo, dude, we're good. We shut down the production, right? And if we shut down the production of more heme, we're not making the ALA and PBG that are causing these neurotoxic and abdominal visceral pain problems, right? So we're going to get a rapid decrease in ALA and PBG. Glucose suppresses the ALA synthetase gene via PGC1 alpha inhibition. Again, that's more than you would probably ever need to know, but it decreases the production of ALA again, right? So both hemin and glucose decrease the production of ALA synthesis, either via direct feedback via hemin or via decreasing the gene production in glucose, okay? So acute intermittent porphyria, again, autosomal dominant due to a decrease in profobilinogen deaminase. We end up getting an increased production of ALA and PBG, especially during times of stress, fasting, estrogens, barbiturates. That leads to the increased ALA, PBG. They're extremely neurotoxic. They can cause autonomic dysfunction in the gut. So you're classically going to get the gut problems, the neuropsych problems, and then the patient can also get some kidney damage and have hematuria as well. All right. To treat them, we're going to give them hemin. We're going to give them glucose if needed. We're going to give them analgesics. And then if they have recurrent attacks, we can consider this RNAi givocerin. Okay, and if you want to read more, screenshot this article, beautiful article, diagnose or going through everything. So again, just really quick, how does AIP lead to diffuse pain? It's again this ALA and PBG. They can get in the liver and systemic circulation. ALA is very similar to GABA, and remember, GABA is our main inhibitory neurotransmitter, so it may interfere with the GABA signaling. This disrupts our autonomic nervous system regulation, and it causes visceral neuropathy. Okay, so again, that's kind of the whole purpose is these ALA and PBG are very, very neurotoxic, messes with the entire autonomic synthesis pathway or the autonomic signaling pathway and can cause a neurotoxicity and mess with all of my autonomic functioning of my abdomen, and then can cause a lot of pain there. So classically, like on physical exam, right, the patient's going to have this colicky abdominal pain. They're not going to have peritoneal signs, but they're going to have this disproportionate pain to physical exam finding. It's very, I think about it very similar to like acute mesenteric ischemia, where the patient has pain out of proportion to physical exam. It's kind of for a similar reason, right? In acute mesenteric ischemia, which we're going to talk about, it's occlusion of vessels, right, via X, Y, or Z, which we'll talk about. So it's not pain to the actual viscus. It's not pain to like our organs. It's just cutting off blood supply, right? It's ischemia. So when I actually press on the patient's abdomen, like I'm not hitting the blood vessels, right? I'm hitting the organs, and those usually aren't, it's not like super painful. Same idea here. It's autonomic destruction of like the nerves. So me actually pressing down on the patient's abdomen probably isn't going to bother them too much, but they're going to be in severe pain, okay? But me pressing down on the abdomen usually doesn't cause them any more pain than they're already in, okay? We may see tachycardia, hypertension, nausea, vomiting, and hyponatremia. The hyponatremia usually occurs secondary to SIADH. Remember, SIADH, ADH is produced in response to high serum tonicity, low blood volume, pain, nausea, trauma, vomiting, okay? So this is probably a pain response, right? An appropriate pain response. So I just told you that these AIP patients likely have hyponatremia secondary to SIADH from pain. What would their volume status, serum uric acid level, urine osmolality, and urine sodium be likely, right? So give me like a broad, a rough estimate, right? We talked about this in my hyponatremia lecture. So if you haven't seen my hyponatremia lecture, this question is going to be pretty hard. If you have, this will be a good test, right? Did you pay attention? Did you learn anything? So pause your screen, think about it. So SIADH, again, if you haven't seen it, go watch my hyponatremia lecture. Volume status, they're going to be euvolemic. ADH causes water retention. It causes stretch of my ventricles. We release ANP, BNP. They go down to the kidney. They cause afferent arterial dilation. We can pee out a lot of the volume we're retaining. We end up in a euvolemic state. The serum acid is usually low. It's usually less than 4, and that's because we've got this dilutional and increased renal excretion of the uric acid because we're maintaining our GFR. Okay, whereas in like hypovolemia, hypervolemia, we have less forward flow. My GFR goes down. Uric acid increases above 4. Again, I explained all this in way, way, way more detail in that hyponatremia lecture. The urine osmolality is going to be inappropriately high. It's going to be greater than 100. ADH is going to cause reabsorption of all that water. We're keeping a lot of my solutes in my urinary system, right? We translocate the aquaporins. We keep the water. The solutes stay in. And then the urine sodium is usually high, greater than 30, greater than 40. The kidneys continue to excrete sodium normally, despite the hyponatremia, because we're in a euvolemic state. So the RAS system usually isn't super activated, right? Because the renin-angiotensin system gets activated by low blood volume, low sodium chloride, and increased sympathetic nervous system activation via beta 1. So that's SIADH. Just a quick recap. Go watch my hyponatremia lecture. It will be well worth your time. So schema for diffuse abdominal pain, right? How can we further break down diffuse abdominal pain into 3 big buckets? So pause your screen, think about some 3 big buckets we could put diffuse abdominal pain into. So I like breaking it down, right, into different categories of bowel, vascular, and systemic, right? These are the way Dr. Mansour breaks it down into his frameworks for internal medicine. And I've kind of like added to it, and I will expand upon them as we move forward. I think it's a beautiful framework to try to think through these. So like bowel, we can consider constipation, IBS, gastroenteritis, bowel obstruction, peritonitis. Vascular are mesenteric ischemias and a AAA. Systemic, DKA, hypercalcemia, adrenal insufficiency, sickle cell, opioid withdrawal, porphyria, which we talked about, angioedema, FMF, and heavy metal poisoning. All right. So let's talk about the bowel causes first. So I made this nice table. If you want, you can screenshot and keep it for yourself, put it into ChatGPT, do whatever you need to do with it. So let's break it down further. Constipation. What would point me in the direction of constipation? A patient who has infrequent bowel movements, hard stools, straining, incomplete evacuation. It might be a chronic problem, right? The patient might tell you that. Imaging findings will probably be normal. We might see large stool burden on abdominal x-ray. And then lab findings, usually normal, right? They may have mild electrolyte imbalances, right? If we're giving them prolonged laxatives. And then if we want to think about the pathophys, right? Usually due to slow colonic transit or impaired rectal evacuation, there may be neurogenic, metabolic, or functional disruption. Okay. IBS, you're going to have recurrent abdominal pain associated with defecation, a change in stool frequency or form, and then it's usually stress related, right? There's usually this neurogenic component to it. Normal imaging, normal labs, the pathophys is a disorder of the gut-brain axis, okay? There's altered motility, visceral hypersensitivity, and psychosocial stressors all involved. It's a gut-brain axis issue, okay? Gastroenteritis, sudden onset of diarrhea, vomiting, abdominal cramps, fever. Maybe they've had recent travel or new dietary exposure. Imaging findings, right? Usually not required. We're not going to get imaging in these patients, or it's not going to show anything. Lab findings, we may see elevated white blood cell counts if it's bacterial. We may see elevated CRP and acute phase reactant. We may see positive stool cultures and infectious causes. So again, it's going to be due to infection-induced inflammation of the GI mucosa. We're going to have increased secretions, decreased absorption, and motility changes. Cholera is like a classic one I like talking about. It causes upregulation of the CAMPs. CAMP is going to cause overactivation of my chloride channels. We get more chloride in the lumen. We're going to draw water into the lumen, and we're just going to have this expansive diarrhea because of all this water that's in the colon that is going to overwhelm the ability to reabsorb all that liquid, okay? Bowel obstruction, we'll see this colicky, abdominal pain, vomiting, potentially bilious or feculent obstruction, right, depending on where that obstruction is. We can see obstipation, so a lack of poop, and then abdominal distension. If we did a CT, we might see dilated bowel loops proximal to the obstruction. We could see air fluid levels where that obstruction is, and we could see collapsed distal bowel, okay? We might see elevated white blood cells. We're probably going to see elevated lactate, showing us there's ischemia. We could see hypochloremic metabolic alkalosis. And on top of that, if they're probably vomiting, we're also going to see hypokalemia too. So one, we're going to lose potassium in the vomit. Two, we've lost blood volume. We go and we stimulate the renin-angiotensin system. What does aldosterone do? Aldosterone keeps sodium in water, pumps out potassium and H+. We're going to lose even more potassium. We're going to lose even more H+, puts us further into this hypokalemic metabolic alkalosis. We could see an elevated BUN to creatinine ratio signifying a prerenal AKI as well. So again, small bowel obstruction, usually due to a mechanical blockage or functional impairment. It causes proximal distension, fluid shifts, and possible bowel ischemia. Okay, and then the last one, peritonitis. We're going to have severe diffuse abdominal pain with a rebound, guarding, fever, and signs of sepsis if it's bad, right? So classic signs of peritonitis where you're reading in a vignette or seeing in a patient, just even touching them or doing a light hit on the table, any kind of movement is going to cause pain, right? They're going to be really rigid. They're going to have guarding. If I do rebound tenderness, if I just touch their abdomen lightly and let go, that's going to cause severe pain because we're pressing down on the peritoneum, the lining of the abdominal cavity that's inflamed. I'm pressing down on it, and then when I release, man, we're causing a massive problem with their peritoneum, and that's going to cause them a lot of pain if it's irritated. We'll probably see elevated white blood cells, elevated CRP, metabolic acidosis. We could see a positive blood cultures and an elevated serum lactate. The pathophys, I've already explained, it's inflammation of the peritoneal lining, typically due to perforation of the bowel of some sort, infection, or chemical irritation. All right. To manage, right, constipation, pretty easy. Lifestyle changes, so increase your fluid fiber intake, increase your physical activity. We got to rule out any red flags that could be causing this constipation, like an obstruction or a tumor. Definitive support, right? We could use bulk forming agents like psyllium, osmotic laxatives like polyethylene glycol, and then stimulants if refractory. IBS, there's a lot of good data on like the FODMAP diet. We can avoid triggers, and then lifestyle is always number one for IBS. If you ever get an IBS question and you're diagnosing it for the first time, it's always stress reduction, exercise, lifestyle management. If they have diarrhea predominant, we can give loperamide, which is a opioid that acts just in the gut. Remember, opioids can cause constipation in the gut. We can use rifaximin, which I talked about all in my hepatic encephalopathy lecture, so I'm not going to go into it now. But basically, it destroys some of the gut bacteria, which can help out with IBS. If it's constipation predominant, we can use PEG. We can use secretagogues. Pain, we can use antispasmodics, TCAs. TCAs are really some of the go-to pharmacological agents we like to use in things like IBS and like fibromyalgia and things like that. Things where we have abnormalities in like the neurogenic axis. Gastroenteritis, fluid resuscitation, oral or IV, depending on how dehydrated the patient is, we're going to correct their electrolytes. We're going to do supportive care. Sometimes we can use antiemetics or antidiarrheals. Sometimes we can use antibiotics for severe bacterial infections. Okay. Usually we don't use them though. Bowel obstruction, right? First line is always MPO, IV fluids, NG tube, and vomiting. Okay. Then if we have a simpler partial, we continue the conservative management. If we see on imaging though, complicated or closed loop, we go to surgery, right? If the patient has failed conservative management, they just keep getting worse, and worse, we go to surgery, okay? Peritonitis, we're going to assess our ABCs, airway, breathing, circulation, IV fluids, broad spectrum, IV antibiotics. If we're thinking about what's going on, right, this is in my gut, really good broad spectrum antibiotics for the gut are going to be things like piperacillin, tazobactam, ampicillin, sulbactam, right, things like that. Ciprofloxacin has really good GI like penetration. Metro is a really good antibiotic as well. So those are all kind of drugs I would consider. We'll talk about spontaneous bacterial peritonitis, but those we usually start something like cefotaxime or ceftriaxone, also a really good option. For peritonitis, we're going to go right to surgery, right? If I ever see peritoneal signs, right to surgery. That's always the right answer. We're going to get source control, right? Find the damaged area and control it. And then if the patient's in sepsis, we're probably going to need to send them to the ICU. All right, just some really high yield points for these. Constipation, right, can be commonly caused by opioids, anticholinergics. Look at the patient's drug list, right? In real life, look at the exam. Does the patient have constipation because they're taking an anticholinergic or opioids? Remember, acetylcholine is my king. It's my neurotransmitter, my king of the parasympathetic nervous system, right? So if I use an anticholinergic, it's going to stop that. What does my parasympathetic nervous system do? It's rest and digest. It's going to help me pee and poop. If I give an anticholinergic, we're blocking the signal from the king of the parasympathetic nervous system. Therefore, we're not going to get that signal to do peristalsis and move food throughout my colon, okay? The Rome 4 criteria is used for functional constipation. I go into that on a later slide on the next one. And then we can think about things like Hirschsprung's disease, where we have a lack of ganglion cell like formation, like movement from the brain to the sigmoid colon and the rectum in a during embryology, right? So that can then lead to delayed meconium passage, and then the squirt sign, where the doctor will stick their finger inside the rectum, release, it relieves the pressure, and the patient passes their meconium. Remember, the way we definitively diagnose Hirschsprung's is via biopsy, right? We're going to actually have to go in and take a sample to determine. If it's IBS, remember, it's a functional GI disorder. It's a diagnosis of exclusion. We're going to use these Rome 4 criteria and then make sure there are no structural abnormalities or red flags. GI, remember, norovirus is going to be the most common cause. Don't sleep on rotavirus, especially in an infant. Remember, with rotavirus, okay, the vaccine, the old vaccine used to be, it had a nice association with intussusception, so invagination of the bowel, okay? The newer vaccines are a lot safer, but they still have a contraindication. If you have an infant who has a history of intussusception, we still don't give them the rotavirus vaccine. Okay, remember, intussusception, the patient's going to have severe colicky pain. They're going to bring their knees up to their chest to try to relieve some of that pressure. They're probably going to have some bloody diarrhea. This is opposed to Meckel's diverticulum, where patients in Meckel's, they have this ectopic gastric tissue in the vitelline duct that never went away. And that ectopic gastric tissue is still secreting some gastrin, which is causing some degradation of that tissue. And then we're sloughing off some of that tissue. So the patient is going to have probably some bloody diarrhea, but a patient with Meckel's is not going to be in any pain. A patient with intussusception is going to be in severe pain that goes on and off, on and off, on and off. We do an abdominal ultrasound. We look for that target sign or that donut sign. We can do things like an air enema and shoot air to try to pop back open the bowel if that doesn't work. Or if the patient has peritoneal signs, we'll likely take them to surgery. Gastroenteritis, if it's bacterial, we might think about maybe we'll see some bloody stools. We'll think about Shigella or EHEC. I went into EHEC in my microangiopathic hemolytic anemia lecture. We'll consider antibiotics carefully. And again, I go into why in that microangiopathic hemolytic lecture. So go watch that. Bowel obstruction. For SBO, small bowel obstruction, adhesions post-op are the most common cause. Look for that in the patient's history, right? If they come in with abdominal pain, they have a history of appendix removal. They have a history of gallbladder removal, right? Look for those kind of things. Large bowel obstruction, malignancy is the most common, colorectal cancer. Air fluid levels, dilated loops, transition points on imaging, all are going to point me towards some sort of bowel obstruction. Bilious vomiting is going to be like more of a proximal obstruction. Feculent, where I'm puking and actual like poop is coming out, right, would be a more distal. We're going to watch for ischemia. And then peritonitis, we've already kind of talked about it, but for spontaneous bacterial peritonitis, any patient with ascites should get their acidic fluid tapped. We should absolutely look for cell count. If their morphonuclear cells are greater than 250, that satisfies the criteria to diagnose SBP. We start the patient on ceftriaxone or cefotaxime without even thinking twice, right? We go, because this is absolutely a deadly condition if we don't treat right away. So again, I'll do a whole lecture on ascites too, because I have a great framework for that too. Patient with ascites, we should tap it. We should look at their protein level. We should look at their cell count. We'll look at their albumin level. If that cell count shows with diff, if that cell count with diff shows greater than 250 polymorphonuclear cells, spontaneous bacterial peritonitis, cefotaxime, ceftriaxone, don't think twice. Get that question right on your exam and move on. Patient with SBP doesn't always have to have a fever, right? You're classically going to look for a patient with a fever who has acidic fluid. They don't always have to. And don't always just look for a patient who has cirrhosis, right? We could have a patient with nephrotic syndrome who has ascites, and then it gets infected, right, by some sort of bowel perfid allows some of these gram negatives, these polymicrobial species, to translocate into the acidic fluid and then cause it some sort of infection, right? So it's not just always patient with underlying liver disease. All right, let's keep it moving. This is the Rome 4 criteria. Not something you really need to understand for USMLE Step 1 or Step 2. It's used to standardize the diagnosis of gut-brain interaction, some of those disorders. Basically, what I want you to get out of this, for IBS, it's recurrent abdominal pain greater than 1 day a week for the last 3 months, plus any two of the following. There's pain related to defecation. There's a change in stool frequency. There's a change in stool form. Okay, there's discomfort. They remove that from the prior criteria to allow for better clarity. So again, we have recurrent abdominal pain greater than 1 day a week for the last 3 months, plus any two of the following. There's pain related to defecation, or the pain stops with defecation. There's associated change in stool frequency and associated with change in stool form. If you want to read more about the new Rome 4 criteria, you can read about with this link here. All right. So those were my bowel causes. Let's talk about vascular causes, right? 3 big ones. We've got acute mesenteric ischemia, chronic mesenteric ischemia, and AAA. So in acute mesenteric ischemia, it's going to be a sudden, severe abdominal pain out of proportion to physical exam. Because again, I told you it's the vasculature. It's not really the organs, right? The organs are losing some blood supply, but it's the vasculature that's impacted. They could have nausea, vomiting, diarrhea. Maybe it's bloody if we're starting to get some necrosis. They might have a history. They're actually probably for USMLE Step 1 and 2 for sure. They'll have a history of some sort of cardiac disorder, especially AFib. When I think about AFib, I'll do a whole lecture on it. But remember, it's classically, could be the right atria. It's classically the left atria. we get some sort of abnormal foci starting from the pulmonary veins that can shoot out. Basically, like AFib is causing just like this chronic contraction of the atria, just like kind of fibrillation like this, right? This stasis of blood in the atria then can cause the formation of a thrombus to form. That thrombus likes to sit in the left atrial appendage. Every now and then it can shoot out, right, and embolize, and can classically embolize to the mesenteric vessels, okay? I'll do a whole lecture on AFib, but again, abnormal foci, usually from the pulmonary veins, causes the atria to kind of contract like this rather than boom, boom, boom. We get like this. It causes stasis of blood, formation of a thrombus formed into the left atrial appendage. For imaging findings, right, we'll do a CT angiogram, classic for USMLE step 2. How do we diagnose it? We diagnose it with a CT angiogram. We'll see mesenteric vessel occlusion, bowel wall thickening, maybe pneumatosis intestinalis, and portal venous gas. Again, just remember the CT angiogram. You'll be beautiful. Laboratory findings, we'll see maybe elevated white blood cell count, absolutely elevated lactate, maybe an elevated D-dimer indicating thrombus formation and breakdown. Again, the pathophysiology, we get some sort of occlusion, maybe from an embolus, maybe from a thrombus, maybe from low perfusion. We get intestinal hypoxia. We can then progress to infarction and necrosis. We get the mucosal barrier failure, and then potentially the bacteria translocate and then cause sepsis, right? Big thing you're going to want to know for your exams, some sort of occlusion of the mesenteric vessels due to emboli from the heart, thrombus from atherosclerosis. We get low perfusion to the gut, to our gut organs, intestinal hypoxia, infarction, and necrosis. Chronic mesenteric ischemia is usually postprandial abdominal pain. It's basically intestinal angina. So remember, angina, stable angina, we get atherosclerosis. When the patient starts walking or they start exercising, there's enough of a oxygen or a demand and supply mismatch because of that stenotic vessel that the heart starts getting a little bit angry, right? It starts getting a little bit ischemic, and you start getting that classic retrosternal chest pain. It's the same idea with chronic mesenteric ischemia. We get atherosclerosis to the mesenteric vessels every time the patient eats. That's kind of similar to me walking if I had stable angina pectoris of the heart. Eating is exercise, right? We're going to shunt all the blood to the mesenteric vessels, and we're going to try to supply the stomach, the intestines, the large intestines, right? So they can help break down and move this food through and reabsorb it. So if we have breakdown, if we have stenosis of these mesenteric vessels, every time I eat and blood gets shunted, a lot of that blood is not making its way to the actual organs because of the stenotic vessel. So you're going to classically see patients with diffuse abdominal pain postprandial, okay? They could have food aversion, weight loss, and a possible bruit, because when blood is moving through these stenotic vessels, that classically shears it kind of across it, and we can hear that classical bruit sound when we auscultate. Again, same idea. We could use a duplex ultrasound, or we could do a CTA. We're going to try to see, we're going to look for stenosis of greater than 2 mesenteric arteries, okay? Your superior, your inferior mesenteric arteries, or your celiac are classic, okay? Lab findings really non-specific, right? If they're malnourished, we might see hypoalbuminuria. Again, the pathophys, atherosclerosis, progressive stenosis of the mesenteric vessels, inadequate blood flow postprandially. We get this ischemic pain, and then it can progress to AMI, okay? AAA is often asymptomatic until rupture. They may have a pulsatile abdominal mass, or they may have abdominal pain if it's actually abdominal pain or back pain, if it's pushing backwards onto my back. If we get rupture, the patient could go into hypotension or shock, hemorrhagic shock, which I talked about in my postpartum hemorrhage lecture. We usually do ultrasound screening for men age 65 to 75 who have ever smoked, right? We classify ever smoking as greater than 100 cigarettes. There's poor literature or like poor data on men who have never smoked getting screened, and women, even if they have smoked, getting screened. So classically, your right answer on board exams based on USPSTF guidelines are going to be a man who's over 65, younger than 75, who has smoked in their life. That's who you're going to want to do an abdominal ultrasound on. We could potentially do a CT angiogram if they're pre-op or if they're symptomatic. Really, our labs are going to be relatively normal. I'm not really going to look at that when I'm trying to figure that out in a vignette or in real life. You could have low hematocrit from hemorrhage. You could have elevated lactate if they're in shock. So again, pathophysiology, smoking is the #1 risk factor. We can get chronic wall weakness. We could get atherosclerosis, which is another massive risk factor. We get aortic dilation. The risk is going to increase with size, and then rupture can cause a life-threatening retroperitoneal bleed and hemodynamic instability. Okay, to manage them, acute mesenteric ischemia. Really, if we have infection, broad spectrum IV antibiotics, MPO, anticoagulation, unless they're contraindicated, because think about the pathophys. If this is due to embolus or thrombus, that's cutting off blood supply, let's anticoagulate. We'll likely maybe need an emergency surgical consult if the patient has severe gut ischemia. We can do an embolectomy if it's an embolic occlusion. We can do a thrombectomy or angioplasty and stenting if it's thrombotic. If there's severe infarction, we can actually take out part of the bowel. For chronic mesenteric ischemia, it's usually outpatient workup. If the patients are stable, we can give them nutrition support. We can think about revascularization of the mesenteric arteries. So we can think about endovascular angioplasty or stenting, or potentially even surgical bypass. For AAA, again, monitor their vitals, get them 2 large bore IVs, get them starting on fluid resuscitation if they're unstable. We'll get emergency imaging. We'll do a CT angio to confirm, and we'll go right to surgery. We'll do an elective repair if their vessel size, if their abdominal aorta is greater than 5.5 centimeters in men or greater than 5 centimeters in women, or is rapidly enlarging. From other literature I've read, most consider rapidly enlarging is kind of considered as more than 0.5 centimeters of growth in less than 6 months. And then we can do an emergency repair, obviously, if ruptured. All right, some high yield points. I've kind of talked about it, but AMI, pain out of proportion to exam, commonly linked to embolism, so look for AFib. Elevated lactate and metabolic acidosis, we'll do a CTA. Chronic mesenteric ischemia, you'll have your intestinal angina. They'll have a fear of eating and weight loss. It's associated with atherosclerosis. When we do the CTA, we need to look for 2 out of the 3 mesenteric vessels to be impacted. So that's the SMA, IMA, and celiac. Okay, we'll treat with revascularization. AAA, we'll look for a pulsatile abdominal mass. We might see abdominal pain, hypotension, pulsatile mass. For screening, we'll do the one-time abdominal ultrasound in men greater than 65 who have ever smoked. And then we'll repair if greater than 5.5 in men, 5 in women, or if it's rapidly enlarged, greater than 0.5 centimeter in less than 6 months. All right, we've talked about a lot so far. We're almost done. We're on the systemic causes here. So let's talk about them really quick. So systemic causes of abdominal pain, we've got DKA. So we're going to look for a patient who's got polyuria, polydipsia, nausea, vomiting, this diffuse abdominal pain, fruity breath from the ketones, altered mental status. We might see ileus, or really, we're probably not going to see much. In labs, we're going to see super elevated glucose, elevated ketones, low pH, low bicarb, elevated anion gap, and elevated beta hydroxybutyrate. Classic DKA, right? It's an anion gap metabolic acidosis. For the pathophysiology, we're going to think about an absolute or a relative insulin deficiency. It leads to lipolysis and elevated keto acid production, and that leads to a anion gap metabolic acidosis. Hypercalcemia can absolutely cause constipation. If you think about your mnemonic for hypercalcemia, it's stones, bones, groans, psychiatric overtones. The groans is the abdominal pain, right? So it can cause constipation, polyuria, vague abdominal pain, nausea, and confusion. On imaging, we might see calcium stones in the urine or in the kidneys or the ureters. We'll see on lab findings an elevated total or ionized calcium and a low PTH, right? So maybe this is PTH driven, or maybe the elevated calcium is coming from somewhere else and it's appropriately decreasing PTH. I'll do a whole lecture on PTH another time. How does this work? Calcium affects the smooth muscle contraction and the CNS. It leads to slow GI motility and an altered sensorium. I always want you to associate hypercalcemia with constipation, polyuria, maybe altered mental status, right? We absolutely need to consider hypercalcemia. Adrenal insufficiency, I did a whole lecture on adrenal insufficiency. It's my one titled Waterhouse-Friderichsen syndrome, so I'm not going into too much of it now. But we could see hypotension, fatigue, diffuse abdominal pain, nausea, salt craving, and weight loss. Really, we're going to see low sodium, high potassium if it's primary, low glucose, low cortisol, elevated ACTH in primary, low ACTH in secondary. I go through this entire workup in that Waterhouse-Friderichsen syndrome lecture, so go watch that one. The pathophysiology, it's due to a cortisol deficiency, which leads to hypotension and hypoglycemia. And if it's primary, we also get aldosterone loss that leads to volume depletion and hyperkalemia. Sickle cell crisis, right? We get severe abdominal or limb pain. We can get vomiting, possible fever, history. We'll also probably see the patient has a history of SCD, or they've been admitted to the hospital multiple times for dactylitis, abdominal pain. They've had a stroke at a young age. They've had this acute chest syndrome. We may see on imaging splenic infarct, gallstones, right, from the hemolysis of those red blood cells, leading to increased indirect bile or bilirubin production, which oversaturates my bilirubin oversaturates my bile, which can then lead to these bile stones forming, these gallstones. If I'm looking at labs for a patient who has sickle cell, right, we'll see our classic hemolytic anemia pattern, elevated LDH, elevated indirect bilirubin, low haptoglobin, and sickled red blood cells on smear. Again, go watch my microangiopathic hemolytic anemia. I talk about why these labs occur. For the pathophysiology, we get vaso-occlusion, we get ischemia and infarct of the organs, right? These sickle cells are really abnormal. They're now very, very rigid. They used to be pliable. They're rigid. They get stuck in these small mesenteric vessels, cut off blood supply to my gut. So that's kind of the pathophysiology there. Opioid withdrawal, you're going to look for a patient who has abdominal cramping, nausea, vomiting, diarrhea, myalgias, yawning, and piloerection. The yawning and piloerection are very specific to opioid withdrawal. So if you ever see a patient who's a chronic drug user who has yawning and piloerection, I absolutely want you to think about opioid withdrawal. They'll classically have normal imaging, normal labs. The way this works, we get a loss of the mu opioid stimulation. It leads to an increased GI motility and increased sympathetic tone, leading to abdominal pain. Porphyria, we already talked about. I'm not going to go into it again. Angioedema, you'll look for a patient who has acute cramping abdominal pain, vomiting, diarrhea, facial swelling. We'll look on CT. They'll have bowel wall thickening. The lab findings will see a decreased C4, a decreased C1 esterase inhibitor if it's the hereditary angioedema. And again, the mechanism of this, we get bradykinin-mediated vascular permeability, which will increase the vascular permeability, way increases because we have an increased amount of bradykinin, and that leads to bowel wall edema. Again, in the hereditary type, we have a decreased C1 esterase inhibitor that allows the complement system to go, 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 go. That's why C4 levels are really low because we're using all of it, right? When I have a low level of C1 esterase inhibitor, we're not able to inhibit bradykinin. Bradykinin goes sky freaking high. Bradykinin is very vasoactive, causes bowel wall vascular permeability, which leads to edema and then severe abdominal pain. Familiar Mediterranean fever is one of my all-time favorites as well. You'll see a recurrent fever with acute peritonitis like abdominal pain. You'll see arthritis and maybe even pleuritis. You're going to have these quotidian fevers. So they occur at like the same time every day. Maybe you'll even see double quotidian. They have one in the morning, one at night. The abdominal pain and the pleuritis and the arthralgias always occur with the fevers. It's this classic autoinflammatory type pattern. I'm going to do a whole lecture on these because I think they're fascinating. It may mimic appendicitis or peritonitis. We'll see an elevated CRP, ESR, and serum amyloid A. Amyloid proteins are acute phase reactants, so they'll be elevated in any kind of acute inflammation. The pathophys, we have a mutation in the MEFV gene. It leads to unregulated IL-1 beta, which can cause serositis. Remember, IL-1 is one of my main acute phase reactant cytokines, going to cause massive inflammation, right? It can cause inflammation of my serosa all throughout my body, all right? And then there's heavy metal poisoning. So things like lead, mercury, arsenic, right? They can cause abdominal colic, constipation, neuropsych signs. So it's kind of similar to AIP, right? When I think about, all right, they've got abdominal, they've got neuropsych. When I think about that kind of stuff, I think about AIP. I think about things like lead, mercury, arsenic poisoning are kind of like really some of the big ones. I also think about like digoxin toxicity and lithium toxicity as well. all can be GI, neuropsych type symptoms. And then I need to look at the patient's history. What drugs are they taking? Do they have any other symptoms to point me in one direction or the other? Um, Really, we may see radiopaque lines in the GI tract. We may look at their bottom of their gums and see those lines in there, right? Those lead lines. We could look at the patient's fingernails and see if they have Mies lines, which are seen in arsenic poisoning. You can, I don't have a picture in this lecture, but you can look up Mies lines and lead lines online. So if we're looking for lab findings, elevated blood lead, basophilic stippling, and lead poisoning. Obviously, elevated arsenic mercury levels in the urine. If we're thinking that, right, we might just have to get a heavy metal screen. So the metal interferes with certain enzymes like ferrochelatase, which can lead to neurotoxicity and GI dysmotility. Um, for management, we don't have to go into all this. I really wanted to spend the time on DKA. And so I'm going to save I have a next slide where I go into the actual 2025 guidelines for how to treat DKA. So I'll save that for them. Hypercalcemia is definitely one talking about. Gonna be on your step 2 exam, how to treat for sure. You're gonna see the patient's gonna have elevated calcium. They're probably gonna have some kidney damage. They're gonna be altered mentally, right? Because elevated calcium can cause neuropsych symptoms. And they're gonna ask you what to do. And they're gonna present you with IV fluids, bisphosphonates, calcitonin, and X, Y, or Z. You always, 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 always start with IV fluids. The IV fluids are going to help dilute out that calcium. They're going to help perfuse the kidneys and make sure you don't get any end organ damage. All right. Then we can go to bisphosphonates and calcitonin. Calcitonin is going to work now. Bisphosphonates are going to take a while to work, but they're going to be the best long-term option. Obviously, treat the underlying cause. If they have a hyperparathyroidism, we'll probably have to take those out. Adrenal insufficiency, I talked about that management in the Waterhouse-Friderichsen, so go watch that. For sickle cell, we'll give IV fluids. We'll do pain control, oxygen if they're hypoxic, treat with any if they have an infection. We can do hydroxyurea for prevention, exchange transfusion for severe crises. If the patient has sickle cell disease and they have a stroke secondary to sickle cell, we're going to do exchange transfusion. We're actually not going to give them TPA. Whenever I do my stroke lecture, I'll go into more detail then. But if you ever get a question on a patient with sickle cell who has stroke, ischemic stroke, we're going to want to do exchange transfusion, not TPA. And I'll go through the mechanism why when I do that lecture. And then we can consider hematopoietic stem cell transplant, which would be curative. For opioid withdrawal, obviously we can do opioid replacement therapy with methadone or buprenorphine, and then counsel them. AIP, we've already talked about. For angioedema, we're going to secure the airway, right? If they're having almost like obstruction of the larynx, we obviously have to secure the airway first and foremost, all right? Give them IV fluids, analgesia. If it's hereditary, we do have a analog to the C1 esterase inhibitor that they're missing, so we could give them that. Long-term prophylaxis androgens and C1 inhibitor have shown promise. And then obviously avoid ACE inhibitors. Everyone knows that one. ACE inhibitors can increase the production of bradykinin or decrease the destruction, right, which leads to the increased bradykinin. If the patient has underlying hereditary angioedema, where their bradykinin levels are already elevated, wow, this is a recipe for disaster, because then you get elevated bradykinin, super vasoactive, going to cause swelling in my larynx, swelling in my face, swelling in my gut, recipe for disaster. FMF, we can use NSAIDs during acute attack, and then colchicine has been is like the go-to. Colchicine's proven great in FMF, so that's what we go to. Remember that inhibits like neutrophil migration. Common side effect is GI disruption, right? Diarrhea. Heavy metal poisoning, stop this exposure. We can do supportive care. If it's lead, right, and the lead levels are really high, we can do chelation with EDTA or dimercaprol. If it's arsenic or mercury, we can do dimercaprol or DMSA. All right, real quick, the DKA updated management as of 2025. Always, always, always. You get a patient with DKA, they're going to ask you next best step. They're going to give you like potassium, insulin, X, Y, or Z, and fluids, right? It's going to be tough to sit. You're like, they should get insulin, right? We always start with fluids first, right? They're going to be severely volume down. Let's get their intravascular volume up, right? Let's stop any further end organ damage. We start with 0.9% normal saline. We're going to consider maybe balanced crystalloids, but again, your right answer on USMLE step 1 or step 2, fluids, isotonic, 0.9% normal saline. Then we're going to start insulin therapy. We only begin the insulin if their potassium is greater than 3.3. We're going to use IV regular insulin. This is a classic USMLE step 1 question. Which insulin do we give? We give regular insulin because it can be given via IV. We can consider some subcutaneous rapid acting insulin analogs if it's mild. But again, the right answer on board exams is going to be IV regular insulin. For electrolyte management, we want to maintain a potassium of 4 to 5. We're going to withhold the insulin if the potassium is less than 3. I go over this mechanism in my pulseless electrical activity lecture, but insulin upregulates the sodium-potassium ATPase, which pumps 3 sodium out, 2 potassium in. So if we give them insulin, we're driving potassium into cells, which is going to lower their extracellular potassium level. If their potassium level is already low, less than 3.3, we're going to make things worse, right, and cause a cardiac arrhythmia. Phosphate we only give if they're symptomatic. Things that could key me in on symptomatic hypophosphatemia, fatigue, altered mental status, seizures, and certain arrhythmias. Adjunctive therapy, we only give bicarb if the pH is less than 6.9. Never going to be the right answer on your board exam. We can then transition to subcutaneous insulin after resolution of the ketoacidosis. We can overlap IV and subcutaneous insulin to avoid rebound, and then watch for cerebral edema, hypoglycemia, electrolyte shifts. We usually add on glucose once the blood glucose of this patient is now like between 200 and 250. So again, first step always for your board exams and in real life, IV fluids with 0.9% normal saline. We can start IV regular insulin if the potassium is greater than 3.3. If the potassium is lower than 3.3, quickly reestablish their potassium levels, give them potassium, and then we can give them insulin. We're going to just maintain that potassium 4 to 5. If their blood glucose then slowly starts going down, it's between 200 to 250. That's when we consider starting to give them some glucose exogenously to make sure they don't become hypoglycemic. A commonly tested topic is DKA typically presents with a serum potassium that's elevated, but their total potassium body is depleted. So let's talk about why. Serum potassium is high initially because the acidosis from this ketone accumulation causes the H+ to enter the cells and the potassium to shift out of the cells to maintain electrical neutrality. I talk about how this happens in my pulseless electrical activity lecture. But again, when we're in an acidotic state, your cells are like, yo, this is abnormal. We're going to drive the H+ into cells to lower that acidotic state. H+ is positively charged, potassium is positively charged. So if we lose some of that positive charge by H+ being driven in, your body's going to pump out K+ to maintain that electrical neutrality, which increases extracellular potassium. Insulin deficiency, insulin can no longer drive potassium into cells, so that leads to more potassium staying in the extracellular space. And then hyperosmolality from the hyperglycemia, it's going to cause a solvent drag and drag some of that potassium out of cells, okay? However, we have elevated serum potassium levels, but we need to look at our total body potassium. Our total body potassium in DKA is classically low. It's classically low due to urinary losses from osmotic diuresis. So from the elevated glucose levels and the elevated ketone levels, that's going to drive a whole bunch of osmotic diuresis through my urine, and we're going to lose a whole bunch of potassium with that. Vomiting and poor oral intake can also lead to further depletion. So yes, their serum potassium is high, but we're also at the same time, we're getting the serum elevated potassium from these 3 reasons. We're also losing a crap ton of potassium via this osmotic drag through the urine via elevated glucose and ketones. So our clinical implication, potassium may be normal or elevated, but replacement is still probably going to be essential, right? We're going to start the potassium repletion if the potassium is less than 5.3. And we're going to hold the insulin if the potassium is less than 3.3. So again, we can start as long as the potassium is greater than 3.3, we can start insulin, but we're going to need to replace, right? If the potassium is, let's say, 5, we're good to start the insulin, but we're going to need to replace because the potassium is less than 5.3. If the potassium is, let's say, 3, we're not going to give them insulin because that's going to make their hypokalemia even worse. We're going to replenish, and then we're going to give insulin. All right. Let's put it all together, and then we're all done. This was a great lecture so far. So putting it all together, we have a 68-year-old man presents to the clinic with progressive diffuse abdominal pain that occurs after meals and has been worsening over the past several months. He reports a 30-pound unintentional weight loss during this time due to avoidance of eating. He denies nausea, vomiting, or changes in bowel habits. His past medical history includes hypertension, hyperlipidemia, coronary artery disease. He's a retired truck driver with a 50-pack-a-year smoking history. His vital signs are within normal limits. His BMI is 19. Physical exam reveals a thin, frail man and no acute distress. The abdomen is soft, non-distended with mild diffuse tenderness, but no rebound or guarding. No palpable masses are noted. Which of the following physical exam findings is most likely to be present in this patient? We have Murphy's sign, flank ecchymosis, periumbilical bruit, absent bowel sounds, and guarding with rebound tenderness. So take a second, pause your screen, think about everything I've taught you, and try to think about which bucket is this falling into, bowel, vascular, systemic, and then think about all the topics we talked about. Figure out the answer, and then associate it with this next physical exam finding. So this patient has classic chronic mesenteric ischemia, right? If we go back, he's an older male. He's got a history of being a truck driver with a huge smoking history. He's got hypertension. He's got hyperlipidemia. He's got coronary artery disease. He definitely has atherosclerosis, as we know, right? And he probably has atherosclerosis of 2 out of his 3, at least, mesenteric vessels like the SMA, IMA, and celiac. We can see his BMI is low, right? Probably because he has this fear of eating. He's had this 30-pound unintentional weight loss, right? He has a soft, non-distended abdomen with mild tenderness and no palpable masses. Less likely to be a AAA in this point, right? So when I look at my different options, right, Murphy's sign would be classic and acute cholecystitis. We have no concern for right upper quadrant pain here or a gallstone leading to gallbladder inflammation. Flank ecchymosis would be positive or would probably occur in hemorrhagic pancreatitis. This guy, we don't hear anything about alcohol use. I have no concern really for acute pancreatitis. No epigastric pain radiating to the back. None of that. I'm not worried about that. Absent bowel sounds. We're not worried about anything that could cause absent bowel sounds in this patient. Those would be more like peritoneal type signs, along with guarding and rebound tenderness, right? That with absent bowel sounds and guarding and rebound tenderness, I'm thinking about severe acute surgical abdomen problems, right? This guy seems pretty stable. I'm not worried about those. So the right answer must be periumbilical bruit. When I have that atherosclerotic plaque, that thrombus, and blood flows across, it can lead to that bruit sound, right? As the blood flows across, it causes an abnormal vibration that we can hear when we auscultate, right? It's classic when we think about like renal artery stenosis. I'm sure at some point you memorize some stupid Anki card where the patient has renal artery stenosis. We get activation of the aldosterone system, right? They have low potassium. They have a super freaking high blood pressure. They've been on 3 different blood pressure medications. It's like a 70-year-old man with hypertension, hyperlipidemia, smoking, right? And then you listen to their abdomen and you hear this like renal artery bruit or the periumbilical bruit, right? Same idea here. We're just talking about the mesenteric vessels, okay? In a patient with fibromuscular dysplasia, same idea. These are going to be our classic like younger females who have intimomedial hyperplasia. It's a genetic problem. We classically impact the renal arteries and my internal carotids. So for those patients as well, super high blood pressure, not really well controlled, even with multiple blood pressure agents, but they're going to be like a younger female usually. And you can hear a bruit in the renal artery and even like below the ears if we listen to the internal carotids. So be on the lookout for that. And again, aldosterone's elevated because when we block off supply to the renal arteries, even though the patient may be euvolemic, the kidneys sense there's really low blood flow, okay? And so when the kidney sense there's low blood flow, it activates the renin-angiotensin system. Aldosterone keeps sodium in water, pumps out potassium and H+. Their potassium goes down when I look at it in the labs. So again, chronic mesenteric ischemia, just on this last one, our framework one more time. So when we think about diffuse abdominal pain, I break it into bowel, vascular, and systemic. When I think about bowel, I think about constipation, gastroenteritis, IBS, bowel obstruction, and peritonitis. When I think about vascular, I think about my mesenteric ischemias and my AAA. When I think about systemic, I think about DKA, adrenal insufficiency, hypercalcemia, sickle cell, opioid withdrawal, porphyria, angioedema, FMF, and heavy metal poisoning. This lecture was an absolute lot. It took me a long time to put together. It is one of the highest yield topics on USMLE Step 1 and for the rest of your life. I'll go over some more localized abdominal pain at a later point, hopefully in the next week or so, because I think it's such high yield information. Go through this lecture as many times as you want. Screenshot these tables I made for you. Use them on your own. Use this framework. Email me or if you need anything or if you have any questions or further topics you want me to cover. Thanks.